Welcome to The Explainer. You know, surgery is something many of us, or our parents, will face at some point. So today, we're going to break down the latest expert guidance that's all about one thing, making that experience as safe as possible for older adults. Okay, let's just start with a number that's kind of mind-blowing. 98 million. That's the number of people in the U.S. who are expected to be over 65 by the year 2054. That's more than double what it is now. And what that means, for sure, is that a lot more older folks are going to need surgery. This isn't some far-off future scenario. It's happening right now. Think about this. Older adults make up about 15% of the population, right? But they already account for over 30% of all surgeries that require a stay in the hospital. That disparity right there tells you just how critical it is to get their care right. Now, to really understand the unique risks involved, we've got to talk about a key concept, frailty. And this is not just a different way of saying old, not at all. Frailty is a specific medical state. It means your body's ability to bounce back from a major stress, like an operation, is lower because your physical, cognitive, and nutritional gas tanks just aren't as full. Okay, so why do we care so much about this one word, frailty? Well, because it's a huge predictor of what happens next. For a patient who is frail, the risk of having a major complication, of not surviving the surgery, or of losing their independence skyrockets. We're talking 2 to 5 times higher. The stakes just become incredibly high. All right, so with those stakes, what can we do about it? Well, according to the world's leading medical experts, preparation is absolutely everything. And that prep work starts long before a patient ever sees the inside of an operating room. The American Society of Anesthesiologists, the ASA, is calling for a much broader evaluation before surgery. First, you screen for that frailty we just talked about, plus any cognitive issues. Second, you bring in a whole team of experts, not just the surgeon. And third, and this is so important, you educate the patient and their family about the risk of something called delirium, which is a sudden state of confusion that can happen after an operation. And to build on that, surgical societies in Europe and America are really championing this fantastic concept called prehabilitation. Think of it like training for a marathon, except the marathon is your surgery. The whole idea is to build up a patient's strength physically, nutritionally, and even mentally before the stress of the operation hits. But here's the crucial point, and it's a theme you're going to see throughout this. All of these steps, the screenings, the prehab, they make so much sense, right? And experts agree they're a great idea. The catch, though, the hard scientific data to back them up is still what we call low certainty. The research is still playing catch-up to these very promising ideas. Okay, let's move into the operating room itself and tackle one of the absolute biggest questions that patients and their families have. Yeah, it's the question we all think about. What's this going to do to my mom's memory? Will my dad be the same after he wakes up? We all worry about how anesthesia affects thinking. So what do the guidelines actually say? Is one type better than another? Well, the ASA dug deep into this. They compared regional anesthesia, like a spinal block where you're awake but numb, against general anesthesia, where you're completely asleep. The conclusion? There is no clear winner. The evidence simply does not show that one is better than the other for preventing that postoperative confusion. And what's really fascinating is that this uncertainty continues even when you're just looking at general anesthesia. You can deliver it through an IV or as an inhaled gas, right? Well, guess what? The evidence is still inconclusive about which one carries less risk for the brain. We just don't know for sure. So the huge takeaway here was that there's no single best anesthesia. The guidelines are really clear that the safest choice is one that's made collaboratively. It's what they call a preference-sensitive decision, which means the patient, the family, and the medical team all need to be part of that conversation. All right, so the surgery's over, but the journey is not done, not by a long shot. Protecting the brain during recovery is every bit as critical as the operation itself. So what can we actually do to be proactive? Are there proven strategies to head off that state of acute confusion and cognitive trouble we call postoperative delirium? Well, the guidelines do point to one specific medication, a sedative called dexmedetomidine. The data suggests it can lower the risk of delirium. But, and this is a really big but, it's not a silver bullet. It comes with a major trade-off, a risk of causing low blood pressure and a slow heart rate, so it has to be managed incredibly carefully. Beyond that one drug, the ASA is pretty emphatic about a whole range of other common meds that affect the brain. things like benzodiazepines, antipsychotics, and others. The message is loud and clear. There are no blanket rules. The risks and benefits have to be weighed for every single patient, every single time. It's all about individual care. And this constant theme of weighing risks and benefits with limited data, well, it leads us to the final and maybe the most important part of this whole discussion, the big unanswered questions. First off, experts agree we need to change how we even measure success. It can't just be about clinical data and complication rates. We need to focus on what actually matters to older adults and their families. Things like, can I go back to my own home? Can I still live independently? That's the real goal. Second, that idea of prehabilitation. It's so promising, but we need to nail down the details. Which specific exercises work best? For which patients? And for how long? We need well-designed trials to turn this great concept into a precise, evidence-based prescription. And finally, to get clear answers faster, researchers all over the world need to start speaking the same language. If we can standardize the definitions for things like frailty and collect data in the same way, we can pool our results and make progress so much more quickly. Ultimately, the core message from all these expert groups is a powerful call to action for the medical community. They're saying, look, we have some really good ideas here, but we urgently need high-quality research to turn all this expert opinion into proven, everyday practice. So these new guidelines show us that while the experts are charting a much clearer path forward, a lot of questions still remain. The journey to safer surgery for our parents, our grandparents, and eventually for ourselves is one where being an active partner in care isn't just helpful, it's absolutely essential.